I'd like to welcome you to our week 6 lecture. I am unfortunately sick this weekend and I don't think I'll be making it to class tomorrow. So I thought that I would audio record the lecture for you. And based on how it kind of goes with the recording, there'll probably be one or two parts to this lecture as we move through. So this week, we're going to focus on the client experiencing breathlessness and dyspnea. When a patient is having difficulty breathing, it can be a really scary event. And it's important as a nurse to really gain a handle of how we treat people in respiratory distress because we treat them from a physiological perspective where we find ways to actually supplement their oxygenation. And then, of course, from a relational perspective where we help to promote comfort and, assure them while they're going through a really frightening event. I'm going to start this lecture by talking a little bit more about the anatomical, physiological, and pathological mechanisms related to hypoxemia. So as you remember, hypoxemia is the state where we have decreased oxygen within the bloodstream. Here you see our normal pulmonary circulation, where deoxygenated blood is coming in to the heart from the superior vena cava and then up through the inferior vena cava from the lower part of the body. So we know that deoxygenated blood passes down through the right atrium, through the right ventricle, and then is pumped through the pulmonary trunk into the left pulmonary artery. As oxygen or deoxygenated blood goes through the pulmonary vasculature, you'll see that at the level of the alveoli, so at the end of the bronchioles here, we're having an exchange of carbon dioxide and oxygen. This exchange is really important, and we're going to talk a bit more about this as we move through the mechanisms of hypoxemia, because pathology, which causes hypoxemia, it usually is targeted here. So our deoxygenated blood moves through our pulmonary system and then comes back to the left atrium, into the left ventricle and then comes out through the aortic arch. So this should be oxygenated blood. So just to show you just a little bit more detail, here's the superior vena cava and the inferior vena cava, down through the right atrium, through the tricuspid valve, up through the right ventricle, through the pulmonic valve, and then into the lungs, okay, where the blood becomes oxygenated again, moves back through the pulmonary veins into the left atrium, down through the mitral valve, and then out through the aortic valve. Now, we know at a lung level that hemoglobin releases carbon dioxide that is picked up from visiting cells and tissue around the body. And in the lungs, the hemoglobin will invite oxygen. And then, of course, the reverse is in effect when hemoglobin reaches body tissue. It's going to release oxygen, which is needed for the Krebs cycle, and it's going to invite CO2 back. Okay, so it really is a carrying mechanism to maintain oxygen and carbon dioxide balance within our blood. Now, the most important thing to remember is that carbon dioxide and oxygen, they move from an area of high concentration to an area of low concentration. So meaning that they always fill in where they're needed. And this concept becomes particularly important when we start talking about lung pathology. This here is just an open circuit drawing of the pulmonary circuit. So oxygenated blood's coming through the lungs, down through the pulmonary vein, into the left atrium, left ventricle, aorta, coming down through the tissues, moving through the body, and then returning into the right side of the heart. Okay, so that's the system that we're following. So the most important question to ask yourself is, what are the clinical manifestations of pulmonary alterations? And you probably have already begun to see these types of alterations in your clients. Altered breath sounds are one of our, kind of most visible findings. We can hear them. Sometimes you can hear your patient having difficulty breathing, or they sound like they have a little bit of fluid on their lungs. They may even have stridor, which is kind of like a high-pitched type of advanced wheezing, because we know that during stridor we actually have Our vascular components are becoming compressed and air is unable to move through. Dyspnea is that notion of the patient having a difficulty breathing. Okay. They may have abnormal breathing patterns. So you may remember back into your nursing 120 lectures that we talked about different types of accessory muscle use when patients are having trouble breathing. So they may have indrawing within their intercostal muscles between their ribs. They may have a tracheal tug, which is a noted kind of pull in the neck at the level of the trachea. We often see that in infants. They may have something called paradoxical breathing, and that's when your chest is rising at a different time point than your abdomen. So it's also called seesaw breathing. And we see that a lot in children, but you'll also see it in adults in respiratory distress as well. Patients with pulmonary alterations may have hypoventilation, meaning that they're not breathing very much. And typically the standard for that is a patient who's looking at around less than 10 respirations per minute. They may also have hyperventilation, which is when the body is breathing too fast. Now, our bodies breathe fast primarily when we have high levels of carbon dioxide. And in some cases, we like to blow the carbon dioxide off in the body, especially if patients are experiencing something like a head injury, where that increased carbon dioxide can cause intracranial pressure or swelling. But hyperventilation can also tell us that something is wrong, primarily that they need more oxygen. When we look at patients' sputum, they could have really thick or purulent sputum, meaning that it's infected. Infective sputum is often yellow or creamy in color. In some cases, it can be green. Okay. When sputum has blood in it, or patients are coughing up blood, we call that hemoptysis. Okay, and hemoptysis means that there's blood within the sputum. Hemoptysis is not just like coughing up clear colored mucus with just a tinge of blood. Hemoptysis is coughing up actual blood. And there's a few pathologies like Wagner's granulocytoma and some other lung diseases that will cause frank hemoptysis. And so when you hear me use that term frank blood, it usually means that we're seeing actual blood, okay? We will also refer to that as sanguineous secretions, sanguineous drainage. We look at patients' cough and how aggressive their cough is, or if there's an absence of cough, because all of that will tell us if something is happening. And then, of course, there's cyanosis. So cyanosis is, a visible demonstration of having decreased circulation to the extremities. So typically you'll see peripheral cyanosis, which is a bluish hue in the tips of the fingers or maybe the toes. Or in more serious cases, you'll see central cyanosis, and that's when patients actually have a change in the color in their in their mouth, and you'll see it in their mucal kind of pockets. Patients also have pain. As you remember last week, we talked about referred pain, and often lung pain, when it's referred, comes up high in the back and can also be in the neck. Sometimes patients will actually have pain on inspiration, depending on what's happening in the lungs. And then finally, there's clubbing. Clubbing is when the fingernails become kind of high and built up. And when you put two fingers together on the opposite hands, you'll see that there is little space when we're clubbing, when it comes out. Okay, so I'll show you what some examples of clubbing look like when we're in class again. So what is respiratory dysfunction? It's a failure to maintain adequate oxygenation. And there's two primary signs that we know that patients are having difficulty with respiratory dysfunction. The first is hypercapnia. That means that they have a high level of carbon dioxide within their body. When we have high levels of carbon dioxide, we transition into a state called respiratory acidosis. In 220 and then into third year, you will learn around how to analyze a arterial blood gas. When patients are very sick, we look at their arterial blood gas, so meaning blood from the arteries, because it's oxygenated blood and it tells us exactly how the patient is doing. And we can decipher if a patient has hypercapnia by looking at that blood sample. The second way we can look at it is we can use a device that looks a little bit like a pulse oximeter in terms of its construction, but it's a hypercapnic monitor that will actually monitor levels of carbon dioxide with the patient. Unfortunately, it is something that is typically attached to a ventilator because it's taken from respiratory effort. Okay, we don't put it on a finger like we do when we're doing pulse oximetry. So high carbon dioxide, that's the first sign of respiratory dysfunction. The second is hypoxemia, and that is a lack of oxygen within the blood. Because if we're lacking oxygen within the blood, we are soon going to start to lack oxygen within the tissues. So what we're looking at centrally within the blood becomes a really important mechanism. Now, there's 4 primary ways that our body becomes hypoxic, okay? The first is hypoventilation. That's when we breathe too slow. The second is a diffusion disturbance. That's when our alveoli have a thick membrane, or there's thickness in the membrane between the alveoli and the pulmonary system, the pulmonary vasculature. And we're going to talk about this in more detail. The third is something called a shunt, and a shunt can be kind of a little complicated. Sometimes a shunt can happen because of anatomy. So when we look in little kids, little babies, sometimes they have congenital heart abnormalities, and they have something called an anatomical shunt. Means that the way that their anatomy is formed causes deoxygenated blood to come back into the left side of the heart. But when people get really sick, they can also develop something called a physiological shunt. And that means that the heart is fine, it looks good. It's that something is happening while that deoxygenated blood is moving around the lungs that isn't allowing it to become reoxygenated. And I'm going to show you some ways that happens. But all you need to remember with the term shunt is that deoxygenated blood returns to the left side of the heart when it's not supposed to. That blood is supposed to be oxygenated. And then the fourth mechanism of hypoxemia is something called a VQ mismatch. The V stands for ventilation and the Q stands for perfusion. So we call it a ventilation-perfusion mismatch. That means that the oxygen breathed in is not transported one-to-one in the body. So even though you're breathing in oxygen, something's happening that's not allowing it to fully diffuse into your blood. So now that we've introduced these concepts, I'm going to talk about them a little bit more. So we're going to go back to hypercapnia. So obviously hypercapnia is increased carbon dioxide in the blood, and it's measured by an arterial blood gas, and we call this a PaCO2 level. Okay? A normal PaCO2 level is 35 to 45. So if a patient has a level over 45, it means that they have a high CO2 level in their body. A lot of different things will cause hypercapnia in the body. Sometimes if we have issues with nervous system disorders and patients aren't breathing enough, we can have issues with hypercapnia because CO2 is not getting blown off. Some patients with thoracic alteration. So let's say we had a patient that had a trauma and they broke, quite a few of their ribs and they weren't able to get really good respirations in. We would see an increase in carbon dioxide because obviously they're not able to breathe that carbon dioxide out. Airway obstruction. Okay, so obviously if we obstruct the airway, the carbon dioxide is not going to be able to leave the body. Sometimes we'll see it with increased work of breathing. So that could be if a patient develops fluid on their lungs or has an infection. And then lastly, often you'll see hypercapnia in patients that have something called an increase in physiological dead space. And as you learn about chronic obstructive pulmonary disorder, it's a good example to show you how there can be CO2 trapping in the lungs because the alveoli aren't strong enough to move it out. So we'll talk a little more over the term about physiological dead space. So what happens when you're hypercapnic? Well, you get respiratory acidosis, so your body's going to try to breathe a little faster. I'll show you on the next slide, but you do get altered electrolytes and primarily higher potassium levels within the body. Because of that alteration in electrolytes and the high CO2, you can be at an increased risk for heart arrhythmias. And as we talked about during our stroke lecture, you can have an increase in intracranial pressures because of the hypercapnia. And that can lead to somnolence, coma, and headache. And then, of course, lastly, hypercapnia and hypoxia often occur hand in hand. In this slide, you'll see an example of altered electrolytes. So we have hydrogen and potassium exchange that's happening during this process of hypercapnia. And what ends up in this process is you have carbon dioxide mixes with water, and it creates HC3, CO3. Okay, so we're getting bicarbonate. When this combines with another hydrogen ion, you can actually have an increase of hydrogen moving into the cell and then potassium moving out of the cell. And this potassium that leaves the cell will end up causing increased serum potassium levels. Hypoxemia is deficient oxygen levels. And like we said before, we measure this by PaO2, which is partial pressure oxygen in arterial blood. And the normal range is 80 to 100 in an adult client. And we measure this by oxygen saturation or pulse oximetry. And as you know from your clinical practice, we like to keep our oxygen saturation at least 92% or higher. So we'll just talk about the four mechanisms in a little bit more detail, and we'll start with hypoventilation. So during hypoventilation, obviously we are breathing slower. So alveolar ventilation is insufficient to sustain alveolar and arterial PO2. We're just not getting enough oxygen in. And that's due to a decrease of air going into the lungs. And because of that, we have a decreased pressure gradient. So we're going to end up having a decrease of PaO2 and an increase of PaCO2. This slide always feels a little overwhelming at first, but all I want to show you here is that we have oxygen coming into the lungs. So let's say we have 100% of oxygen. It moves into the lungs and it slowly gets used. So this is a normal pressure gradient. Here we have carbon dioxide that's starting to move out of the lungs and to be excreted. And here we've got 40 millimeters of mercury coming out. So at the alveolar level, usually 100 millimeters of mercury of PaO2 is coming in and 40 millimeters of mercury of CO2 is going out. Okay, so this is just showing you here in venous blood, of course there's going to be less oxygen, right? Because the oxygen has been used at a cellular level. And there's going to be a little bit more carbon dioxide that is leaving because the tissue has released it. In our arterial blood, see how there's a high level of PaO2? There's 95 millimeters of mercury because we have oxygenated blood. And our PCO2 is 42 because we had some exchange, but of course we're going to still have some CO2 in our blood. It's just important to remember that all CO2 and all oxygen are not released, okay? They move from an area of high concentration to an area of low concentration. So here, the alveolar levels, the venous levels, and the arterial levels. Now what happens in hypoventilation here, instead of getting 100 millimeters of mercury of oxygen, now we're only getting 60 because we are not able to breathe in as much oxygen as before. And here we're still having, a decent exchange of CO2, but we still can have a risk of increased CO2 building up in the system. So what causes hypoventilation? Well, medications. So for example, narcotic analgesics and opioids can cause hypoventilation. We talked about that last week in class. Pleurisy or infections within the lung because they're painful and often patients won't take that big breath in. Or conditions that cause thorax muscular weakness, like ALS or other nervous system disorders that make it difficult for patients to breathe. Okay, and just a definition of pleurisy here, it's an inflammation of the pleura. And remembering with inflammation that there's often pain that will occur. So how do we manage hypoventilation? Well, we can give narcotic antagonists like naloxone or Narcan if it's due to an opioid. We always increase the inspired oxygen, so we like to put our patients on a higher level of oxygen to help support them. And in some very severe cases, we will use mechanical ventilation. Okay, so we will put someone on a mechanical ventilator. The second mechanism of hypoxemia is what we call diffusion disturbance. So it means that there's a slowing in the diffusion of oxygen or carbon dioxide across the respiratory membrane. So when we look at how gas normally goes across the respiratory membrane, we look at a pressure gradient, and then we also look at surface area. So that's the distance through, like the area through which diffusion occurs. And I'll show this to you on the next slide. And then we also look at the solubility of gas as well, because this will be dependent on how a diffusion disturbance will unfold. And then again, the distance over which the diffusion occurs. So let's show you what this looks like. So pretend this box here is your alveoli. So we have an alveoli that is exchanging oxygen and carbon dioxide. This is the surface area of your alveoli. Okay, it can only be so big. So this is the amount when we're looking here. So this is your pulmonary system. This is the surface area for diffusion. So if we have a lesser surface area, of course, we're not going to be able to get as much carbon dioxide and oxygen over. If our surface area is bigger, then of course we're going to have more gas diffusing. So that's the first part of a diffusion disturbance that we have to look at. The second is the distance over which the diffusion occurs. So remember that there are layers between the alveoli and your pulmonary vasculature. And sometimes, depending on the disease condition, these can really thicken up. And the thicker and wider they get, the longer it takes gas to go back and forth. So if we reduce our surface area, like I said before, you will have less area for gas exchange. And if I increase the distance, it's going to take longer for gas exchange as well. So what causes a diffusion disturbance? Basically, anything that can cause thickening within that space, so alveolar cell carcinomas or cancer. Conditions like interstitial fibrosis. So think of fibrosis as something getting really thick and hard and scarred. So we see that interstitial fibrosis in that area of diffusion that thickens between the alveoli and the pulmonary system. And then there's pulmonary edema. That's when we get actual fluid in the lungs, and the fluid sits in the alveolar sacs. So because of that fluid, it causes it to take longer to perfuse oxygen and carbon dioxide in and out of the lung space. Okay, so we consider that a diffusion disturbance. You're going to see me use pulmonary edema as an example in some of the other mechanisms as well. So here's an example of interstitial lung fibrosis. So you have a healthy tissue here. This is a healthy tissue in a 90-year-old. Okay, so just a little bit of damage there. Here is progressive massive fibrosis in a 40-year-old minor. So this is someone who's actually had frequent chemical exposure and destruction of alveoli. So their alveolar membranes have become really thick and fibrotic. And here's an example of sarcoidosis. This is an inflammatory condition of the lungs. So you can see the effects of some of the inflammation. Excuse me. This is how pulmonary edema works. So here's the alveolar space, and you'll see that the edema is sitting in between. So you're having a lot more difficulty exchanging oxygen up through the lungs because of the edema. So how do we treat a diffusion disturbance? We always have to figure out the cause. So if it's interstitial fibrosis, we have to look at trying to stay or treat that mechanism of injury. So maybe we focus on inflammation. If it's pulmonary edema, we're going to correct the pulmonary edema, and we do that through giving a diuretic drug like furosemide and often some drugs that strengthen the heart. So we always correct the cause, because if you don't correct the cause, you're just going to keep having to treat the patient. Now, of course, it's the physician's mandate to identify, isolate, and correct the cause. But of course, as nurses, we can help to bring that potential cause forward. Secondly, we administer oxygen. So we want to keep our oxygen saturation greater than 92%. So we'll talk a little bit more in this lecture around how nurses can administer oxygen delivery equipment. You need to manage anything that is going to increase their oxygen demand. So fevers cause an increased metabolic demand, increased heart rates do, activity. So often these patients are on bed rest when they're on oxygen, right? We never have a patient on high flow oxygen walking laps around the unit, right? If they're that sick, they need to be resting. And then finally, we correct the distance and surface area when possible, and we can do this through medications, and we'll have some examples of that as we move through different pathologies throughout this year. So we've talked about hypoventilation and we've talked about diffusion disturbances. Now we're going to talk about shunts. Shunts are a little more confusing, but they're very interesting when you do see them clinically. So the basic principle I want you to remember for this course with the shunt, it's when blood arrives at the left ventricle without coming into contact with ventilating alveoli. So basically, deoxygenated blood is returning to the left side of the heart, and it shouldn't be. There are two types of shunts. There's an anatomical shunt, so that's a congenital cardiac heart defect, and typically there's increased flow through bronchial veins in these types of conditions. So we'll talk and show you a little bit of these anatomical shunts. Rob Tillman in your patho class will do a very lovely lecture around anatomical shunting next semester when he talks about the heart. Physiological shunts, this is where we have mismatching of the ventilation and perfusion ratio. And the cause of this are destructive lung diseases that impair ventilation. And this can also be precipitated through cardiac failure, which interferes with the movement of blood throughout the lungs. So the heart and the lungs really work in consort together, and when one organ is suffering, the other will eventually too. So here's an example of an anatomical shunt. You'll see the red is arterial blood, the blue is oxygen poor blood, and the purple is mixed blood. So in this, it's called a patent ductus arteriosus, or a PDA, and it's a common type of congenital heart defect that is easily fixed through surgery in infants. But you can see that right between the pulmonary artery and the aortic artery, there is a little pathway. So because of this pathway, you're getting a mix of venous blood here and arterial blood. Okay. So this would be corrected through surgery. This is a very complicated type of heart defect. It's called tricuspid atresia. And so you'll see here's our right atrium, but there's a closed tricuspid valve, and there's an underdeveloped right ventricle here. Okay. So blood is basically coming in through the right atrium and going up into the lungs. And then you're having difficulty because of the shared components here where you're getting mixed blood in. Okay, so it's coming in through the left atrium, left ventricle, coming into this underdeveloped right ventricle and getting mixed. So the difficulty here is here and up here. Okay, so they would require surgery to get back into normal pulmonary function. So when we're mixing blood like this in the heart, what's happening is mixed blood is going out the arterial system and tissues are just not getting enough blood. Often in babies, one of the first signs of a congenital heart defect, like PDA, is often baby might have trouble feeding, like they get really short of breath or turn blue while they feed because they just can't meet the demand. Now, those were anatomical shunts, so now let's talk about a physiological shunt. So here's a normal heart where we've got oxygen-rich blood coming back to the body. And here's heart failure, where we actually are getting a dilated ventricle and reduced volume. So remember, a big dilated ventricle is not a good thing on a heart because what happens is the heart starts to lose its elasticity and then you can get problems with pump function. Okay, dilated hearts don't pump very well. So what happens here is we've got reduced volume and a dilated ventricle, and we are not getting as much volume out of the heart as we should. So that means we have lesser volumes coming into the lungs, less blood coming into the lungs, and therefore less oxygen moving out. So here's a normal unit of oxygen. Okay, so this is what would be coming back into the left side of the heart versus a shunt unit, meaning that this same unit went through the lungs, but because the lungs were not effective, they are having less oxygen come back. It can also be because the blood itself is not being pushed through the lungs fast enough that they can also have decreased oxygen coming back as well. So what causes shunts? The most common thing that you're going to see is atelectasis. So that's the incomplete expansion or collapse of alveoli caused by hypoventilation, obstruction of the airways, or compression. So here's an example of atelectasis, okay? And then just showing you some anatomical features of atelectasis within the lungs. Pulmonary edema also causes shunting because we have fluid in the alveoli. So it makes sense that as blood is coming underneath the alveoli, that we're not getting the same oxygen exchange that we should be. So we have less oxygen that's coming into the body and coming back into the left side of the heart. This is just what alveolar edema looks like, or pulmonary edema, at a little bit of a closer level. What happens is you can get what's called a continued capillary leak, and what ends up happening with that is you get a loss of surfactant production. So surfactant makes the alveoli slide. Okay. What happens if we have increased edema is you get what we call a massive diffusion blockade or stiff lungs. And the pathology where the body develops stiff lungs is called ARDS. So ARDS tells us that the patient is in an acute respiratory distress syndrome. So what's happening is the lungs are becoming too stiff and you're unable to ventilate fully within the in the alveoli, and then you start to drop your oxygen levels. ARDS is a pretty advanced concept, and most of you will not see this condition unless you work in critical care units because these patients are mechanically ventilated. And there's a special type of ventilator that we use with ARDS. It's called a high frequency oscillator. But remember, I promised to tell you a couple weeks ago, one of the things that's happening right now in the population that we're seeing die from vape-associated deaths is that these patients are going into ARDS. And they're thinking that it's occurring through a mechanism where the vaporizer coils are not heating the juice inside of them to a high enough level. So there's bacterial growth that's occurring within them. And then that bacteria is entering into the lungs with residue, and it's causing a massive inflammatory response, and then putting the body into ARDS. ARDS is a very overwhelming condition to see in real life. Patients are very, very sick, and it has a very high mortality rate. And that is because they die from the issue of shunting, right? So they have these blocked edema, alveolar edema. They have a massive inflammatory response going on in their body, and then they have all this deoxygenated blood coming back into their left side of their heart, and because of that deoxygenation, they go into shock and they go into organ failure. So examples of shunting, we've talked about atelectasis, pulmonary edema, and localized pneumonia. We'll have a similar response to what I was talking about in terms of like the vaping as well. It's just that you are having alveolar collapse and infection, and you've got two major things happening, your inflammatory response and then of course shunting. Okay. This just shows you what alveolar pneumonia looks like, right? So pneumonia is going to collapse your alveoli and cause lung collapse as well through the consolidation of fluid. We can also see shunting on aspiration. So it makes sense if you aspirate like vomit or something else into your lungs and it causes occlusion of the alveoli. Of course, you're going to have less oxygen units passing through. Okay. And how do we manage a shunt? You have to decrease the amount of the shunt. So we try to open up the non-ventilating alveoli. So we typically will do that through mechanical ventilation. There's a special thing called positive end expiratory pressure, or PEEP, that we use to help open up those alveoli. And then, of course, we treat the cause. So if your patient has a physiological shunt, they're pretty sick, okay? And often they'll be in the intensive care unit. Our last section, and then we'll take a break, is the mechanisms of hypoxemia ventilation perfusion mismatch. So we're mismatching ventilation, so breathing in, to perfusion, which is oxygen going to tissues. The most common cause of hypoxemia in chronic and acute lung disease is VQ perfusion mismatch. And it will arise when some regions of the lungs are hypoventilated or hypoperfused. So again, you're going to see that there's some common examples: pulmonary edema, aspiration, atelectasis, acute respiratory distress syndrome, chronic obstructive pulmonary disorder, and pleural abnormalities will cause a ventilation perfusion mismatch. And you will get most of this content when we talk about respiratory disorders in Patho next semester. And really, our management is administer oxygen and correct the cause. So I'm hoping you're starting to see the common themes here: correct the cause and give oxygen. All right, we'll take a quick break and then I will record the second part of this presentation.